for joining. I think we'll go ahead and get started then. Well, I'd like to again welcome you to our webinar on transplant, and I'm really excited to you'll I think learn a lot from our first speaker is Dr. Preethi Yerram. And then we will go on to Doris will be speaking, and then Candy, and then after that we'll have Jeff, and they'll share their experience. So again, one of the things I wanted to let you know is at the end, please feel free to raise your hand and we will take questions. So with that, I will turn it over. Dr.
Thank you,
Yerram.
Mary. I'm so happy to be here today, and I'm so excited to see so many of you here. And it seems like we have people from every corner of the states, even Alaska. Um, yeah, and so many states. I'm really excited. Let me start sharing my screen here. Okay. Can you all see my screen?
Yes.
Okay, perfect. Let me get this out of my way. Okay. All right. So kidney transplant evaluation, it can seem like a lot, and it is a lot. So I want to break it down and hopefully make it a little bit easier and kind of take away the intimidation that is associated with the transplant evaluation. So okay, can you see, is it advancing for you all?
It is.
Okay, good. So the main thing I want to impress upon you is that it may seem like it's a lot, you're doing it all, and there is a lot riding on the patient themselves, but I do want you to understand that you're not alone in this journey. Although, like I said, kidney transplant, even the evaluation, getting a transplant can feel very overwhelming. So today we'll talk through what to expect and keep in mind that your transplant team will be your partner and wants to support you in this process. So who is on the transplant team? So whenever you go for your first evaluation, usually that's when you will be meeting the entire team. So the transplant coordinator is kind of your main guide. They'll be the ones that you would be talking to. They'll be the ones reaching out to you, kind of to give you updates on what's happening with your process, with your evaluation, when they may schedule a test for you, or if you get on the list, whether you're being activated or you're being made inactive on the wait list because something is going on. So whatever it may be, they are your main guide through this whole process. There would be a social worker on your team as well, and they would be providing emotional support, and also kind of dealing with any practical needs you may have throughout the process. Financial coordinator, they'll be the people that would be talking about insurance, whether you would be qualifying for a certain medication, or are you going to qualify for listing at a particular center or not. So these are the things that they would talk to you before you even start the process. So it differs from program to program, but typically this is done at the very front end of the process. When a referral comes through to a program, a financial coordinator is usually going to either reach out to you, or they'll kind of check on your insurance at the back end and say, yes, you will qualify to come to our program. And then they can also help you as the process is going on. The next person is dietitian. There is going to be a lot of changes in the eating plans, and what to do, what not to do with a transplant, and when you are on dialysis. So there's going to be like a sea change when it comes to how you eat before and after transplant. So they'll be guiding you through that process. Transplant nephrologist is somebody like me, so a kidney specialist that specializes in kidney transplantation, the immunosuppression, the anti-rejection medications that you'll be taking, and they'll be the ones that you would be seeing pretty much indefinitely after the transplant as you are caring for your new transplant. And transplant surgeon is the physician that performs the surgery, so you would be seeing them before the transplant when they are kind of evaluating you, but also they'll be the ones to perform the surgery, and you'll be seeing them for a period of time, usually after the transplant, but also if there are any other surgical complications, you may be seeing them for a little bit longer. So that is your transplant team. And then, once you kind of, meet with your transplant team, what are the steps? So even prior to meeting your transplant team, the referral has to go through. And this, it's important to keep in mind, and I want to impress upon you that it does not have to come from your physician or your dialysis unit or anything like that. So there are few programs, I think, that will require, some sort of information sheet that is going to be filled by either your dialysis unit or your physician. But a lot of programs actually encourage you to reach out and self-refer even. If somebody is thinking, oh, I'm not, being referred for a transplant, that is not necessarily the case. You can actually pick up your phone, call the number, just Google a transplant center that's in your area, and you can call and say, I'm interested in a transplant. Please send me the packet, and you can get started that way. So once that process is done, usually somebody will reach out from the transplant center and they'll do a phone interview, try to get as much information as possible. Then they'll arrange the first visit when, you will be meeting the whole team that I described in my previous slide. Then the testing phase commences. And there are times when you would meet the transplant team and, the team may determine that somebody is not a candidate to move forward after that process because of, some red flags that may come up. And these could be something like, an active cancer or a cancer that has been just treated and you have to wait for a certain period of time. Or maybe somebody's weight, they have to reach a certain target. So they'll tell you why you may not be a candidate or why you cannot proceed with the next step. And then, once you get those kind of, goals to work towards, you can go home and kind of, have a plan to work on reaching those targets and then revisit the evaluation. But if the team determines that you meet the preliminary criteria to move forward with the evaluation, then the testing phase begins, and this will be determined based upon what medical conditions you have. So it's not a one size fits all. There are definitely lots of tests that we do for most patients, but certain tests will be dependent upon the specific conditions a patient has. And finally, once all the testing is done, the transplant team meets and reviews all the testing, everything that's related to the patient, and then they decide whether the patient, meets all the criteria to get a transplant, and then they will be added to the wait list. So once you're added to the wait list, it does not mean that you're actively receiving offers. So there is actually like active status on the wait list and inactive status on the wait list. So active status means that everything is in order. So if a kidney becomes available and you come up for that match, then you're ready to accept that kidney. Sometimes transplant centers will list patients on the wait list, but inactive, meaning like they have done everything else. But for example, maybe they're just waiting for a colonoscopy to be done, or maybe they have a couple of teeth to be extracted, and we are waiting for those. So we know that the patient is going to finish these things, and we want to add them to the list and keep them inactive until they are finished with that process. So those are the kind of times where a patient can be listed but they are not actively receiving offers. So sometimes it's confusing because patients think, oh, I'm on the list, and that they're just active. Once they're on the list, they are always like available to receive offers, but there are two different statuses on that, so that's something to keep in mind. And then once you're added to the wait list, you're kind of waiting for your match kidney. There are several factors that determine how long you'll wait for a kidney. It depends on the geography. For example, we are a small center in the Midwest, and I would say before the recent changes came into effect for the allocation system, our patients were waiting on an average about 3.5 years for a kidney transplant. Currently, our patients are waiting about 4 to 5 years, and it also depends on like your blood group. So usually, blood group O patients and B patients wait longer. If you have a lot of antibody levels, meaning if you have received, for example, a previous transplant, or if you've received a lot of blood transfusions, or like, for female patients, if they have a lot of pregnancies, those all can make your antibody levels go up, and that will make you wait longer for a transplant. So there are several factors that would play into how long you would wait. So those kind of are the steps for the evaluation. And we talked a little bit about getting started and meeting the team. So I'm not going to repeat that. Like I said, you could self-refer yourself. There will be a phone interview. Information will be mailed to you. You will visit multiple team members on the first visit. We request your medical records for review and all of that. So in terms of the testing and decision, again, we went through this as well. So there is an evaluation phase, specialist referrals, depending upon your own medical problems, will determine what kind of tests we need to do. We review all the results, and then we talked about the active and the inactive statuses. I think I see Wen maybe raising their hand.
Oh, yes, because can you speak slowly a little bit so the program can recognize the voice and translate to the Vietnamese
Oh,
from the
okay.
beginning now she don't
I
recognize
have a really bad habit
the
of speaking very fast. I will try my best to slow down. Okay. Thank you for letting me know. All right. So in terms of testing, what do we do? So this is pretty routine in terms of like what we would do for any other major surgery, right? For example, if you're having an appendectomy, like elective appendectomy, I'm not saying, like emergent or whatever, but we would be doing a certain number of tests to make sure that you can get through anesthesia and it is safe for us to do the surgery. So a lot of the testing that we do for kidney transplant is pretty similar to that in terms of like we want to make sure that you can go under anesthesia safely and you can come off of anesthesia safely. So this would include usually heart testing. So we would do an EKG. So just kind of, we put all those leads on you, and then we'll take a strip of your rhythm of the heart. So that's a very routine test that we do. Echocardiogram, this is an ultrasound of your heart. So, people that have done that before would remember that as like, a little bit of gel put on your like chest, and they'll take pictures of your heart with a probe. They'll kind of rub it on your chest and take pictures of your echo. So that'll show you like how the heart is squeezing. Are there any valve leakages, or like, are there tight valves, things like that. Stress test is, basically kind of, stressing your heart to see if there are any blockages, because obviously surgery, especially major surgery, is considered to be a very stressful kind of situation, and that can trigger heart attacks, for example, right? So we want to make sure that we recognize any of those risk factors ahead of time and treat you before we take you to surgery. So chest X-ray is just like a plain picture of your lungs, and other organs that can be seen in the X-ray. So it'll show us it's kind of like a basic test. If there is something glaring, like fluid on your lungs, or like there is a mass or something. But we will do more specific tests if there is something that shows up like a red flag or like something concerning on the chest X-ray. We will do more definitive testing like CAT scans. And so the personalized testing comes into play when, the basic test might show an abnormality, for example. So if we do see some sort of abnormality on either the EKG or the echo or the stress test, then we would send you to a heart doctor to make sure that, if you have heart problems or if anything further needs to be done in terms of like, angiogram, or if there is a blockage, maybe they may have to put a stent in your, one of the arteries in the heart. So after the heart testing, we also want to check your blood vessels and blood flow. The reason we do this is because, when we are hooking up a kidney into your body, we need to make sure that the kidney gets enough blood flow. And whenever we are hooking up that kidney, we also want to make sure that the kidney is getting blood flow, but it is not diverting blood flow away from your legs, for example, right? Because where we connect the kidney, the blood flow is going to come to the kidney, and it is also going to go down to your legs. So in people that have peripheral vascular disease, for example, so if they have already blockages in the arteries that are going to their legs, and if you add another organ here, the kidney, that's going to divert blood flow away from the legs, you can affect the blood flow to the kidneys, and that's going to be problematic, because then your legs can become ischemic, or like they can develop gangrene without enough blood flow. So that's the reason we do the CAT scan of the abdomen to make sure that there are not like severe blockages that will affect the blood flow to the lower extremities. We also do the blood flow test to the neck and the brain because again during surgery, if there is a low blood pressure, you will affect the blood flow to all these various organs. So that's why you do have to check the blood flow to the brain and the lower extremities and all of that before we can decide it is safe for us to hook up that kidney. So infection screening, the reason we do infection screening is because, again, transplant will require us to put you on anti-rejection medications, and these are medications that will suppress your immune system. So in other words, you will not be able to fight infections as well as you used to before. So that's the reason we really push patients to get vaccinated for everything they can get vaccinated for ahead of time, but also we have to make sure that they do not have any active or hidden infections. So we test for HIV, hepatitis B and C, tuberculosis, other viruses, syphilis. So there is a whole panel of tests that we do to make sure that we are like looking at these risk factors and that you are not going in with an active infection, which can flare up significantly if you receive those anti-rejection medications. So cancer screening. So why is cancer screening important? For two reasons, because anti-rejection medications can increase your risk of cancer. So if you have some sort of precancerous thing that can obviously turn into cancer. Also, because if you have cancer and then your life expectancy is not very long, then it may not be appropriate for you to get a kidney transplant and then receive the anti-rejection medications, which can further accelerate the cancer growth. So that's why we want to do cancer screening ahead of time. You have to do all your age-appropriate cancer screening. So in women, usually pap smears, mammograms, colonoscopy for men and women after a certain age. Also maybe earlier, depending upon your risk factors. Men will have their prostate, PSA checked. If you do have a previous history of cancer, depending upon what kind of cancer it is, how extensive it was, there may be a need for 2 to 5 years of wait before you can be cleared for a kidney transplant. So what additional testing do we do? So in addition to all the tests that we have already done, usually like blood work, so basic labs, but we also want to make sure that you do not have a bleeding or a clotting disorder. So there may be certain specific tests that we would do based on your history. If somebody may have had clots in the past, or they may have significant bleeding issues. So we need to identify those ahead of time for obvious reasons because we are going to cut on you during surgeries, and also after surgery you will be not very mobile. You'll be resting in the bed for a long time. So we don't want you to clot. Have clots in your legs that may go to your lungs, or worse, we don't want you to clot off the blood flow to the kidney. So we have to look for those kind of things ahead of time. So we also do brain scan in patients that have polycystic kidney disease because of the risk of cerebral aneurysms. So again, this is something sometimes these aneurysms can rupture. Again, like I said, having a major surgery is a stressful situation. So we don't want anything to trigger these kind of catastrophes. So we have to screen for those ahead of time. So if there is any history of liver disease or something that shows up on any of the imaging studies like CAT scans or whatever we do along the way, we may send you to a liver specialist or a GI specialist. In terms of patients having COPD or a significant history of like smoking, if they are on oxygen, those are things that if you are on continuous oxygen and cannot come off of the supplemental oxygen, you will most likely not be a candidate for transplant. But if you do have history of COPD and this is some sort of a temporary issue, then we may have to send you to the lung doctor for extra testing. So mental health and support is really important because it is a very extensive process. There is a lot going on, especially after the transplant. You will need support as you're recovering from the surgery. There may also be certain things that may come up after the transplant. For example, maybe surgical issues that may require extra support and extra kind of help at home. But also if something has come up, for example, if we are suspecting a rejection, we may say you need to come to the hospital and get admitted so we can do a biopsy. So you may need somebody to drive you up to the hospital, maybe take you back and forth to appointments or like for blood draws. So there is a lot of things that can happen after the transplant, especially, or, as you're getting ready to get a transplant, if you live quite far away, you may want to bring someone to, kind of drive you through from wherever you live to the hospital and all of that. So it's very, very important to have a robust family and friend support system. We also want to make sure that, once you get a transplant, you are able to afford the medication. So as I said, the financial coordinator, the social worker usually will, talk to you about these ahead of time, because the last thing we want is for you to get a transplant and not be able to take those medications, because without that, your kidney will fail. You'll end up in rejection. So we have to, really have a solid plan for you to be able to take these medications after the transplant. Readiness to follow medical instructions. And, some programs will require drug testing, and these may be done randomly depending upon the center-specific protocols. So there are certain situations where transplant might not be right? We want as many of our patients to get transplanted as possible, but sometimes that's just not the right thing for certain patients. So safety first, the whole goal, I usually tell my patients, the whole goal of transplant is to make life better for you than it is right now on dialysis or pre-dialysis. But the worst thing is like for us to try to do something and then make things worse for you than they already are, right? So that's not the goal. The goal is for us to improve your quality of life, improve whatever is going on, and kind of build up on that, not make it worse. So if there are certain situations like temporarily you may not be a surgical candidate because of whatever that's going on, maybe you just had a heart stent or heart surgery, there may be reasons for us to say, okay, let's wait until you recover from it, or maybe you just got over a bad accident, or where you had to go through rehab and all of that, and you're getting stronger. So those are temporary reasons where we would say, okay, let's wait and make sure you get stronger, and then we can transplant you. There are active infections. We want to treat them first. Active cancer, as I said already, you won't be a candidate for transplant until after you're completely treated and wait for a certain period of time. Illegal drug use. And there are reversible kidney problems. So if you're on dialysis because certain like acute insult caused that issue, we hope that that would be reversed and you can come off of dialysis. So in those situations, it is not appropriate for us to do a transplant because we hope that this is a reversible issue. If there are any uncontrolled mental health issues, that can be a potential contraindication, and transplant may not be right. If you're not taking medications, because that's a sure way to lose the kidney and end up in rejection. So that would not be, that patient would not be a candidate. But it's important to keep in mind that a lot of the issues that we think are going to be in the way of somebody getting a transplant can be fixed. There are certain things that may not be, but most of those can be fixed if you work diligently towards, getting over those, and the transplant team can help you through those. So what do you have to know about staying on the wait list? So once you go through the whole process, everything is you've jumped through all the hoops, you've met all the criteria, and you are on the wait list now. So what are your responsibilities as a patient? So you have to keep the transplant center updated about anything that comes up with your health. Are you having any health problems, or have you had a recent surgery, or did you have to go into the hospital? Because those may actually require you to become inactive on the wait list, because you don't want to go, get a kidney transplant if you, for example, got admitted with a heart attack, right? So we need to know all those kind of things. So it is, we can safely do the transplant after you have recovered from those kind of things. We also require annual checkups. So you'll be coming back to the transplant center every year while you're on the wait list to make sure that you're still healthy. You'll do certain amount of testing to make sure everything is still in order for us to proceed with the transplant. So one last thing I want to say before I end. So there is such a thing called multi-listing or dual listing. You may have heard different words used for that. What that really means is that if you are on the wait list at a particular center, you can go ahead and list at another center, and it depends on the insurance. You can list at more than one center as long as your insurance approves. And I think Medicare obviously is is a much better option if you want to do that, because I think if you have a private insurance, there may be limitations on what they'll approve and what they will not approve. But the point is that you can list at more than one transplant center, and that can actually increase your chances of receiving a transplant more quickly. So this is something that I want you all to keep in mind. The nice thing about it is most transplant centers will accept testing from another transplant center. So it's not like you have to go and do the testing at another center, like, right from the beginning. All you need to do is like, again, have a referral to that transplant center, and they can request records from the other centers that you may be already listed at. But you do have to go and meet their team and everything, but they are able to use the listing from another center. So that's something I want you to keep in mind. So in summary, I want you to go home with these points. Take your transplant team's help. They are there for you, and we want our, patients to be on the wait list, be active, and get a transplant as quickly as possible. So the transplant team wants to help you. And I personally, usually tell my patients, some patients will tell me like, I don't want to nag, the transplant coordinator. And I'm like, nag away, that's the way to do it. And that'll show that you're motivated, and you have to be your best own advocate, right? Yes, there are family members that will, want to advocate for you, but you have to be your own best advocate. And so if you want to call your transplant coordinator and find out, hey, where am I at with this process? What do I need to do to get active? Go ahead, make that call, and use your transplant team's help. And every test is there to protect you. We are not just doing it because we have to do it. There is a reason for why we do a certain test, because they all have a purpose, and it is meant to protect the patient. We want the patients to be honest, because it helps us to pick the right kind of testing and help you in the right way, find the right way to get you qualified for the transplant. Don't give up. Like I said, a lot of problems or a lot of hurdles that you come across can be fixed. So just, be diligent with the goals that you're given, and try to, again, take your transplant team's help, even your dialysis, social worker or dietitian, whoever it may be. They all want to help you and succeed. And stay involved. Again, going back to you being your own best advocate, stay involved in the process, ask questions, and don't hesitate to speak up. And I think that's all I have, and I'm happy to take questions. Are we reserving questions for the end? Okay.
Yeah, we're going to save questions to the end, just so we make sure we have enough time. So feel free, at the end, you can either raise your hand or put a question in the chat. What a fantastic overview. That was great. I always learn something new. So thank you so much. That was wonderful. With that, we'll move over to Doris, and she can tell a little bit about her journey with transplant.
Hey, thank you so much. I'm going to keep mine pretty short. So if you have questions, save them for the end, and I'll answer all the missing parts that you may have questions about. Because I know there are other panelists we want to hear from. But I am a transplant patient. I got my kidney almost 10 years ago now. And just listening to Dr. Yerram, there's like all these memories and emotions that come back. It was a long process, but great care. I was first diagnosed after I applied for and was denied life insurance. And so what I wish I knew then was that I can be looking at my labs and asking my doctor about, like, can you tell me how my kidneys are doing? Kidney disease is a silent disease, and I didn't know. I didn't know I had kidney disease. And in fact, for a long, long time after I was diagnosed, I just felt really normal. And so I always tell other people now, it's like, ask your doctor to get your kidneys tested. It is a simple, easy test, and so that's really important. But I was diagnosed originally with polycystic kidney disease, and later on we found out, no, it really was not that. It was really probably something called IgA nephropathy. Some of my symptoms were foamy urine, dark urine, and so if you see anything that's off, again, always ask your doctor. I eventually got my transplant from a living kidney donor, and I remember when I was first diagnosed and first told that I needed a kidney transplant, I think I was just completely shocked, overwhelmed. I kind of froze in my tracks, and I thought, I don't know what kidney disease is. I don't know anybody in my family who has kidney disease, much less need a transplant. But there I was, and I had a family member who was getting tested for me, and was going to donate, but at the last minute they weren't able to, and then that happened again. Somebody else got tested, and almost we even set a transplant date, but something happened, and that didn't happen. So it really can be an emotional roller coaster, and of course a physical one too, because you're just so exhausted. I said that it's a silent disease. It is until the very end. I think when my kidney function dropped to about 3 or 4. I mean, I was tired, but I thought, well, this is just getting older. I guess, this is just what aging is like. You're tired. But it wasn't until my kidney function dropped that low before there was, metallic taste in my mouth, itching all over, brain fog, no appetite. So some of those symptoms don't appear until long after you are at a point where you cannot reverse kidney disease. So again, I always urge people, get tested and find out from your doctor, how your kidneys are doing. Because oftentimes there are things, if caught early enough, that you can do. So anyway, I got my transplant eventually from somebody in my extended family, and he was 61 at the time that he donated. He's, in his 70s now and just doing fantastic. He's still active. He's hiking mountains all over the world, in Mount Kilimanjaro, Machu Picchu, and so it just inspires me to see someone who can continue to stay active, continue to face challenges regardless of age or any setbacks. We just keep on going. So I've been transplanted almost 10 years from a living donor. Living donor kidneys are often last longer, but not always. I mean, just a deceased donor kidney is just as good oftentimes. And I am doing well. I do have to stay very careful to not get infections. I always wash my hands. I wear a mask whenever I travel, because now that I take the anti-rejection medication that keeps me, I'm at higher risk of becoming ill. Because I take those immunosuppressive medications. But other than that, I'm doing really well, and I'm going to stop there because I know we want to hear from others, and save your questions for me for the end. Thank you so much. Mary, you're muted.
Mary, you're muted.
Oops, sorry, I was on mute there. Doris, thank you. A wonderful presentation. And I'm going to move right on to Candy.
Thought it was me next. Hi, everyone. My name is Candy. I spent I spent 13 years on dialysis and got my transplant about 4 years ago. So I was transplanted in 2021. I think I want to just talk about some of the challenges I had with getting my transplant, so we'll kind of know some of the ins and outs. So while on dialysis, I was on peritoneal dialysis, had gained a lot of weight, and your BMI has to be a certain number to get a transplant. So I decided to, at the time they were doing lap band surgery. So I did lap band for a little bit. Wasn't a good process, wasn't a good surgery for me. So we removed the lap band, and then about 3 years later, I waited a while. About 3 years later, I did gastric bypass. And with gastric bypass, I got to the BMI that I needed to get my transplant. And so in that process, I had a lot of other issues like um, the doctor, I can't think of her name right now. The doctor, she talked about a lot of antibodies. I had a lot of blood transfusions when I first got sick. At the time, I didn't know that I was sick, so I kind of crashed into dialysis. And one of the things I had to do was get a bunch of blood transfusions. And then after having gastric bypass, I had a bunch of blood transfusions. So that caused me to be 100% sensitized, which, as she said, makes it much harder to get a transplant. I did learn something later on in life that you could get blood transfusions without antibodies. And so after I found that out, I started requesting those because I did have them quite often. Even after I got listed, I had a bunch of different blood transfusions. So to make a long story short, I kind of listed in our area. She talked about that, about how long you're on the wait list. I was A positive, but I was on the wait list for about 5 years because of the antibodies. And if you get gastric bypass, it can cause like some oxalate issues. It's one of those tests I have no idea about, but they talk about it quite often if you have gastric bypass and you're doing peritoneal dialysis. It's not a problem if you do hemodialysis, but it is a problem if you do peritoneal dialysis. And I was doing peritoneal dialysis. So I listed in the state that I live in for quite a bit. And I was kind of an advocate, just like we do today, like talk to people. And we were talking to some leaders, and I was on a call with two other people that had already been transplanted. By now I had spent 13 years, almost 13 years on dialysis at that time. And so she was telling me that I should multi-list. I did not know about that back then. They talk about it a lot now. So I multi-listed in a state right next to me. The city was about 4.5 hours away, so it wasn't very far for me to get to. I listed there, talked to some doctors. I did not have to go through all the testing. They just pulled them from another hospital. And so I did that, and I was transplanted 5 days after. So it's very important to get multi-listed just for those reasons. You never ever know what other hospital can do or what they have. And they were able to treat the antibodies that I had. So I had some treatments after the transplant, and was able to keep my transplant without any issues. So 4 years post-transplant, one time I had some anti-rejection, and so they fixed that, and I haven't had any issues since. So I think that's like the short end of my story. It could get longer, but we're gonna keep it at transplant. So, but the only other thing I would probably talk about is just anti-rejection medicines, like really talking to doctors and see what those medicines do to your body, and so you'll kind of know a little bit about it. I feel like I wasn't as educated on what medicines do, in the long term. So that's another question or something to talk to the doctors about, just to kind of know the ins and outs. As she said, always advocate for yourself and always speak up for yourself. It's always the best option. Thank you.
Thank you so much, Candy. That was great. As you can tell, everybody has just a little bit of a different journey. And so we will move right on to Jeff, and I'm sure he's going to be sharing some other interesting journeys through this process. So thank you again, Candy, and I'll turn it over to you, Jeff.
Thanks, Mary. Hi. Hey, good afternoon, everyone. My name is Jeff Nelson. I'm living in the west side of Wisconsin, in La Crosse, and near the Mississippi River. My story is it's been a real journey, I think, as you've been hearing so far, and my story starts with my family. I have polycystic kidney disease, which is a genetic disease, and so my mother had it, my brother had it, her father had it, and his father had it. So it went back to the 1800s. But we were all diagnosed around the year 2000 when my mom was first diagnosed, and because we knew it was genetic, then I was tested, and then through an ultrasound, and though I wasn't having any symptoms at the time in 2000, we confirmed that I did have dialysis. I wish I would have had more life insurance then, but after I was diagnosed, it was too late, but that's a whole separate thread all by itself. I really didn't start to show symptoms or get close to 20% kidney function, where I was really feeling tired, until 2013. And it was about that time that some friends of mine with the PKD Foundation helped mount kind of a kidney campaign, where I was looking to socialize, my ask for somebody to share their spare kidney with me. And so with the help from some friends who put together this kidney campaign, I got a billboard in Milwaukee, Wisconsin. I was one of the first people to get that billboard, and it got a lot of media attention. And through the media attention, and particularly the local newspaper, my cousin Mary saw that, and she decided to call the transplant center, and she got tested, and she got enrolled into the program. But I didn't find out until months later. This was, the transplant center did not tell me that Mary had was getting tested, and then one day I'm on dialysis, and the hospital calls and makes me an offer and asks if I'd like to have my cousin Mary's kidney, which of course. So there were some other business to take care of, and I finally had that kidney transplant in February of 2014. But some issues came up during the surgery, and we had some trouble after the surgery with the kidney starting up and getting going. And after about 9 weeks, they did a kidney biopsy, and they found that the kidney was no longer viable. And this kidney was, even though it was a living kidney and it came from Mary right next in the surgical suite right next door, it just wasn't going to work out. So they ended up removing that first kidney, and then I was on dialysis for about 3.5 years. While I was in that, on those 3.5 years, I really was careful to watch my diet. I never skipped a dialysis treatments. In fact, I was able to go back and do the easy math of 3 times a week times 52. I had 550 dialysis treatments total. And but I did enjoy life while I was on dialysis. I took vacations out, and one vacation I had 6 dialysis treatments at 6 different clinics, going out to Colorado. So, there is life during dialysis. I started getting offers in 2017. So now, after that failed transplant, I did get back my time from UNOS, because I first enrolled with kidney transplant programs in 2010. Which is when I hit my 20%, and so, I started having offers, but the in some cases it was I had to wait, or one case I came to the hospital, they did a bunch of blood tests. Because of that first kidney transplant, I had an enormous amount of antibodies, just like Candace related to, I also took actions to try to reduce those antibodies, but and just having high antibodies does not mean you're not going to get a kidney transplant. It just means it may take a little bit more time, but it's not impossible. And for sure for me, I got that call, and they told me to stop eating, stop drinking, and get ready and come on to the hospital. The next morning, when we thought that surgery was going to start at 5 o'clock in the morning, and it was already 8 o'clock, and I started asking the nurses what's going on, they said, "Well, we're just checking the antibodies." And I'm like, "Well, of course it's the antibodies. It's always the antibodies." And but what it ended up being is that the new kidney was such an amazing match. I couldn't believe that I had such a low rejection risk or antibody match against the new donor kidney. So it ended up being a really, really good match for me. So. After that kidney transplant, which happened in July 2017, a couple months later, I started to develop blisters and some other problems. And it turns out that that kidney itself had a virus called CMV, I think a cytomegalovirus, and it was a very difficult type of strain to treat. And I also had another virus called BK virus. And so, I think to the doctor's point, they look at a lot of different things about testing for you, but you have to also realize too that the kidney itself that donor may have had other viruses that your body may not have seen before. And this is something that the doctors have to be, on the lookout for, and you as a patient have to bring it to their attention. And to everyone's point so far, you really have to be a strong advocate to make sure that the doctors know what's going on. You bring symptoms to their attention. You don't try to hide it, and you don't try to walk away from it. So something else too that was after my transplant, and from a dietary standpoint, and I think the doctor touched on this earlier about how things just go upside down. I mean, there was a point while I was on dialysis, and I had to be very careful with phosphorus. I was taking binders and everything I could do to manage my dialysis and phosphorus level so I didn't have calcification. Now, with my new kidney, I can't get enough phosphorus. I'm literally drinking Diet Coke, prescribed by the doctor, to help try to improve the amount of phosphorus that I have in my serum blood. I also can't get enough magnesium. I can't even get my magnesium up to the reference range. So there's just some of these things that could happen to you. And I think as I like to close and say that when it comes to kidney transplants and what you need to know, I think you need to remember that transplant is a treatment modality. It's just a treatment modality like hemodialysis or peritoneal dialysis. It's just a better treatment modality than dialysis, and certainly a lot easier to work with. And the things don't always go well. and you should be surprised. You know, I was at 1% of that kidney transplant center's failures of kidney transplants that year, and I don't want to wish that trauma of losing a kidney to anyone else, but it can happen, and you need to know that. And your mileage is going to vary. You just don't know what your creatinine level is going to be, cold ischemic time. There's so many factors that run into it. And you know what? In the end, just as long as you get a kidney transplant and you can live a better life, that's what's important. So thanks for your time. I look forward to answering any questions later.
Thank you so much, Jeff. As you can see, there's, everybody's had just a little bit different journey. And I think, it kind of just tells you a lot. But I think if there's one that rang through is being your own advocate. And I think that's an important aspect to really be your own advocate and, make sure that you're communicating. It's really important to communicate with your providers and making sure what are your goals, and making sure that you continually, if something you feel is going on, that you talk to them. So hopefully this webinar has been very helpful. And with that, I'm going to open it up if there's any questions.
Mary, we did have one question in the chat.
Oh, yep.
Is it true that private insurance is preferable over Medicaid patients? And I think that question is for Dr. Yerram.
I'm not sure I'm the right person to answer that, but usually I know that if you have like Medicare, you need like a supplemental, right? Like 20 for you to cover the 20%. But if you only have Medicaid, it probably depends upon the state where you're at and the program itself, if they accept Medicaid as the sole payment source. So I think it really depends upon the program. But I think, some programs might, accept Medicaid as the sole source of payment, and you might be okay with it. But the main thing is to make sure that your transplant medications are going to be covered by your Medicaid, the drug program, and so all of that is going to be usually determined by the financial coordinator ahead of time.
I have a little bit of information about that, just a little bit.
Okay.
So, when I first went on dialysis, I had a private insurance. I did eventually get Medicare, but I got a Medicare supplement that was not Medicaid. What I noticed different, because I know someone else that has kidney issues, what I've noticed the difference when you get the supplement that you pay for is that you don't have as many challenges when you're going to like other doctors for other different things. You don't have a whole lot of copays, you don't have a lot of turnaround. And then there's also a program called the American Kidney Fund. As long as you're on dialysis, they will pay those premiums for that secondary insurance. And they also will pay that secondary insurance the first year you get your transplant. So it gives you time to kind of figure out if that's what you want to do, or if you want to go, like if you qualify for Medicaid, you want to do it that way, or if you want to do it a different way. But you're right, different states do different things. I'm in Illinois and they say we have a really good policy here. So it's not as expensive as it is in other states.
And Kendra, I think to your point, I think Missouri has the Missouri Kidney Program. So if you are Medicaid eligible, Missouri Kidney Program can pay your like premiums and then the spend down or whatever it is, I think, so yeah, you're right. I think it depends on what resources are available in a particular state.
I think you've heard a wealth of information today, and hopefully that's been really helpful. We do have some resources also that Kelly actually shared, and there's one on actually for patients, and then there's a toolkit that our forum has put together, and it's a patient toolkit, and we also have another one on transplant for healthcare providers. And she also put in that I personally am a transplant recipient as well. And I wrote a book because there wasn't anything out there for children. And so this book is actually in children's hospitals, but it's also being used with dialysis patients, trying to explain to, younger children kind of what they went through. So I was diagnosed when I was 9. And so the story goes from the time I was 9 to the time I had my first transplant. when I was a teenager. So hopefully those all those different resources are helpful. And also there was another resource on, kind of a workbook on transplant that was shared as well. So I think that hopefully you're getting some information, and hopefully that everything that's been shared tonight has been useful and helpful and inspiring. And hopefully if you're either a transplant recipient or if you're looking at transplant, that we were able to answer some of your questions tonight. So with that, I'm going to give one more. Is there any questions yet from anyone? I'm not hearing any. We will be having another webinar coming up, and that was just put in also in the chat, and it is actually called the Derek Forfang, and it's our second one. And I have to tell you, the physician that actually speaks is phenomenal. So we're actually October is Mental Health Month, and so it's really how to kind of thrive when you're dealing with health issues and just uncertain times. So hopefully you might be able to join us, and there is also a survey, and we would really appreciate any input that you can give us. If there's new topics that you'd love to have us do, just give us feedback on what we presented. We would love to hear from you. So thank you so much for attending tonight. And with that, I guess I'll give you a couple minutes back.
I think, Mary, there is a question in the chat
Oh, is
about
there?
water intake after transplant. I think David asked what water intake. So are you asking how much water you need to drink after transplant?
Yes, I've heard different
Okay.
things about that.
Yeah, so that's one of the things that Jeff was
Oh, I
alluding
see.
to, how it's like a polar opposite of what you are expected to do on dialysis versus after transplant. So when you're on dialysis, you're constantly hearing, don't drink, don't drink, don't drink, and then after transplant, you're like, drink, drink, drink. So it's gonna be, and usually we say, try to drink at least, 2 to 3 liters of water, fluids a day. But again, it depends on your labs, if what other medications you may be on. So it's not like, the 2 to 3 for everyone, but that's kind of the general range. And then, the rest will depend upon what is going on with you in terms of, other medical issues, other medications that you may be on that may affect your fluid status.
Okay.
Yeah, David, this is Jeff Nelson speaking. Because as a transplant patient for so long, it became a lifestyle not to drink and to manage my fluid intake. And so I didn't have to push myself to drink more, but the doctors reminded me that it was very important that I not become dehydrated. And because of the kidney connection to the ureter, to my bladder, that if I felt like I had to go and not wait. But it was important to stay hydrated and maintain a good fluid level. I'm sure you can always overdo anything and drink maybe too much water, but it is a transition that you may have to make as a dialysis patient to put yourself back into drinking water like a normal person.
Yeah, because at first, before I got um, told I was my kidneys were down, I used to drink a lot of water, and then all of a sudden I had to stop drinking water a lot because I used to drink, I don't know, maybe 2 to 3 gallons a day because I worked outside, and then all of a sudden say, hey, you can drink 40 ounces. It was like a big change, and it was kind of hard. It was hard, but I did it. And now I hear once you get your kidney, they don't expect you to drink a whole bunch of water to flush it out. So that's why I'm like, it's from one change, one extreme to the other, and then back to the other extreme.
It sure is. I see we do have another question in the chat. What is the one important advice you would share with patients who are on the transplant list? And so any of our speakers want to jump on that one?
I can, Mary, and I think I can
Thanks, Jeff.
summarize it in what my wife told me, which is eyes on the prize. Stay healthy, watch your diet, maintain your health with your doctors. Do not skip dialysis treatments. You know, my transplant center called my dialysis center to say, so how's Jeff doing? Is Jeff healthy? Is he, you talk to the nurse, you know, is he compliant? You know, does he do what you tell him to do? You know, how's he doing? And well, the dialysis nurse says, oh my gosh, Jeff's our best patient. Please give him a kidney transplant. He's waited a long time, and I have, and so that's how I prepared for my kidney transplant. I was just compliant, did what I needed to do, stayed the course, worked the program.
And I add one thing to Jeff. The other thing I've heard a lot about in just doing advocacy work is make sure you do those yearly checkups, because they'll take you off the list if you haven't done a yearly checkup. Sometimes people forget, they don't schedule the appointments. And so if you do that, they will remove you. You have to start all over again. Not the time, I don't think. You just have to go through the whole process again.
And I see we do have one other question. I didn't get about the 2 transplant list. So what that is that multiple listing is what it's called, is if you're interested in, you know, getting a transplant, you know, maybe in your city, there's 2 transplant centers even. And so, you know, what we were encouraging is that, you know, maybe multi-list in different centers, because maybe they're you know, their donation rate is higher, or maybe they, you know, I think you heard earlier about people that are sensitized and they might be able to treat it. So if there's nothing wrong with being able to multi-list in with another center. So hopefully that answered that question. And I think we're at time. So I appreciate you all, and thank you so much for coming tonight, and look forward to hopefully you can join us in October. Thank you again.
Good evening,
Bye-bye,
everyone.
everyone.
Thank you.
Bye.
Thank you.
Thank you.